Hi everyone, welcome to the 2020 BJSM PhD Academy Awards. My name is DePhillipo. I'm going to take you through my recent PhD thesis on meniscal ramp lesions. Before we get into the results, I want to briefly introduce ramp lesions and discuss their clinical significance in sports medicine. The ramp lesion involves the tearing of the posterior medial meniscus at the meniscocapsular junction. They are of specific interest due to their reported blind spot when viewing arthroscopically. Their name is derived from the arthroscopic appearance of a downward slope or ramp. Because of the anatomy, this ramp area creates a potential hidden space, thus resulting in misdiagnosis and failure to recognize ramp lesions on both MRI and at the time of surgery. By definition, ramp tears are associated with ACL tears. This is the number one research topic in sports medicine. Besides the acute physical disability, one of the main reasons for this is that 1 in 2 patients who tear their ACL will go on to develop post-traumatic osteoarthritis. We know the meniscus is vitally important for joint preservation, but also the medial meniscus specifically is a secondary stabilizer of the ACL. Biomechanically, previous research has shown that ramp lesions can significantly increase knee kinematics, thus attributing to ACL reconstruction graft failure if not managed appropriately. However, this topic is controversial due to the ability of ramp lesions to heal without surgical repair because of the reported vascularity involving the meniscocapsular junction. Therefore, our research team developed a plan to systematically evaluate meniscal ramp lesions and see how they affect ACL reconstruction. We accomplished this through what we call a research pyramid, which is a multi-level study algorithm used to improve single-purpose research objectives. We started with improving diagnosis. We found a 17% incidence of ramp lesions with ACL tear patients. Here, preoperative diagnosis rates improved by 24% with the finding of a posterior medial tibial bone bruise pattern. Next, we performed a quantitative anatomy study and found a shared common attachment between the meniscocapsular and meniscotibial attachments, which was supported by histology. These data indicate that these two structures may function collectively as a single anatomical unit. This led us to test both the meniscocapsular and meniscotibial structures in a biomechanical model. Despite the increased knee kinematics with both types of ramp lesions, there were no significant differences between tear patterns, providing further support of a shared common attachment. As a result, we redefined and developed an anatomic, biomechanically validated meniscus ramp repair technique. And lastly, we went on to implement this repair in a clinical study. Results showed that ramp patients had significantly more knee laxity on physical exam compared to controls. There was a higher ramp incidence in patients with delayed surgery, and there were no significant differences in outcomes between groups, with 88 to 92% rates of return to sport and 0 to 4% ACL reconstruction and meniscus repair failure rates. Collectively, the most important findings of this thesis were ramp lesions have a high incidence and low rate of detection, so we must actively look for these tears in ACL tear patients. Meniscal ramp lesions do cause an increase in knee biomechanics. We should look to repair them surgically. Delayed ACL surgery was associated with increased ramp lesion incidence, and performing an inside-out meniscus repair has demonstrated safety and reliability with low failure rates for meniscal ramp lesions. In conclusion, some clinical recommendations can be made from this thesis work. 1. Anatomic ACL reconstruction with preference of patellar tendon autograft in patients with ramp lesions. 2. Inside-out repair for unstable ramp lesions. And 3. Early surgical treatment for ACL tear patients. Special thank you to my family, friends, and mentors who made this PhD possible.